This lecture is going to be an overview of stroke and specifically ischemic stroke. You will have a second talk that will address hemorrhagic stroke. These are the lecture objectives. You'll need to, at the end of the lecture, be able to describe the types of strokes and their incidence, describe the mechanisms of ischemia, describe risk factors for stroke, and describe preventive measures for stroke and its acute treatment. There are several key words you should also know by the end of this talk, and these include ischemia, embolus, hemorrhage, infarction, lacune, penumbra, watershed zone, anticoagulant, antiplatelet, thrombolytic, and TPA. And we'll walk through each of these throughout the talk. Let's start with some definitions of stroke and TIA. Stroke is an abrupt onset of focal or global neurological symptoms resulting from a disease or diseases of the blood vessels. These blood vessels could be located anywhere within the nervous system, including central nervous system, including the spinal cord. Symptoms of stroke will persist for at least 24 hours, and patients who have an acute stroke will have abnormal imaging. A transient ischemic attack is a focal neurological deficit lasting less than 24 hours. Most TIAs will actually resolve within 15 minutes, and patients who have a TIA will have normal imaging. These definitions are important to know for your STEP exam. Stroke is the 5th leading cause of death in the United States. Actually, we're doing better because it was the 4th leading cause of death 5 years ago, and it has dropped given that we have several acute therapies we can give for stroke. Each year, around 800,000 people have a stroke, and the annual stroke mortality is about 160,000 people. Stroke is incredibly expensive for our nation. It costs about $34 billion annually. And the majority of strokes, 87% of strokes, are ischemic. This is a picture of depicting the prevalence of stroke by age and sex. And what you can see is that stroke tends to be pretty common in both men and women, but the prevalence increases with age. So you can see that over the age of 80, we're approaching a 14% of the population having a stroke. In addition to having a first stroke, many patients will have recurrent stroke, and this occurs most commonly within 5 years after the first stroke. So what you can see here is that the percent of patients who broken down into different demographics that will have a recurrent stroke approaches around 20% overall, although it may be more likely to occur in older white men and women. Stroke has a high mortality rate, but is especially high in the southern regions. And this is due to a combination of factors, but this particular picture depicts those counties that have very high rates of mortality from stroke. And of course, we're doing a little bit better in the Chicago area. Disability after stroke is quite common. Using data from the Framingham study, at about 7 years post-stroke, a third of survivors will need help taking care of themselves. 20% will need help when walking, and 70% have impaired vocational capacity. Now, I want to point out that the Framingham study and these statistics were provided prior to the widespread use of thrombolytic therapy in acute stroke. So these numbers have actually improved with the advent of new medical therapies. So let's talk first about stroke subtypes. Infarction or ischemic stroke is going to be the most common stroke subtype, 85 to 87%, and this is broken down into a number of categories. The first are large vessel atherosclerotic disease, again the most common of the group, small vessel lacunar disease, cardioembolic disease, and hematologic or other. Hemorrhagic stroke, which makes up about 15%, is defined as either in the subarachnoid space or the intraparenchymal region. And again, we'll have a second talk addressing these. The mechanisms of ischemia, there are 3. So thrombosis is a common mechanism, the most common, and this is when a clot will form at the site of infarction. Usually you will have a plaque, and the infarction will occur at the end of the distribution of the blood vessel. So what you can see here is you can see a plaque that's overgrown an artery, and down here is where we essentially have the injury to the brain. The second type of mechanism is an embolic mechanism, and this is when a piece of the plaque breaks off and travels down the blood vessel and then obstructs the blood vessel. So we can see that in this picture here, where in the top picture where we've got a little piece of the plaque that's coming down and it's going to block this blood vessel and subsequently cause injury to the brain. Now, there are some risk factors for embolic stroke, including atrial fibrillation or deep vein thrombosis, especially in patients who have a patent foramen ovale. Hypoxic ischemia can also occur, and this is when you have hypoperfusion or hypoxemia, leading to an injury typically in the watershed zones. And I'll show you a slide of what those zones look like. And this bottom picture here on the right shows us what that looks like visually. So just to remind you of the vascular anatomy, you guys have learned this anatomy in the brain labs. And on the right here, we have a picture of the distribution of those blood vessels. It's very important to know the vascular anatomy because that will tell you essentially when you have an infarction that you've localized based on the patient's examination and history, you can go back and sort out which vessel is responsible. So when we think about the mechanisms, atherosclerosis is one of the most common mechanisms for ischemic stroke. And on the left, you can see a picture of what this plaque formation looks like within the blood vessel. On the right, you can see a picture of this clot going through that plaque and essentially stopping the blood flow to an area of the brain. So you can easily see if you don't have blood, especially in large vessels, you're going to injure quite a large amount of cortical territory. Let's talk a little bit about ischemic penumbrum. So when you have a clot or a plaque that's blocking the blood flow, you are going to have an area of the brain that has permanent immediate damage. But then there's going to be an area of the brain around that we call the penumbra that's at risk. And the reason why we want to understand this concept is that we can actually, with very good aggressive treatment in the hospital, save that tissue that's at risk, or the penumbra. So what we can see here on the left is a graph that shows you kind of the relationship of time and the cerebral blood flow. And again, what you can see in the darker portion is that we have the irreversible damage and then that penumbra that's around it. On the right, this is depicted kind of visually, and below you can see some special imaging that shows you, especially in the C picture, the red piece is the brain that is injured and damaged irreversibly, and the green around it is where we've got the penumbra that's at risk, but we may be able to save. So the penumbra is a little bit different than a watershed zone. So a watershed infarction, again, that can occur with hypoxemia or hypoperfusion, are those areas in between those major vessels that tend to not have as rich of a blood supply. So if you have areas between two vessels with less of a blood supply and you have hypoperfusion, they're going to be the ones that are at risk of being injured. So Tom Hepner likes to describe this as thinking about a lawn with a sprinkler system. And sometimes you'll have at the end of where your sprinkler head is, you'll get less water flowing, but close to the sprinkler head, you'll have a lot of water flowing. So if you turn down the water coming through your sprinkler system, there may be areas between your sprinkler heads that don't get water at all or get very little water. And that's the same concept of kind of a watershed area where you're not getting enough blood flow when you're hypoperfusing through the vessel. So there are a few zones, and we see this really in the cortex, where we have an area of watershed that's at risk between the ACA and MCA, and then between the LCA and MCA, and finally between the MCA and PCA. And this kind of visually depicts where those areas are. Large vessel ischemic stroke can occur because you have occlusion of one of the major arteries, and these can include the vertebral, the basilar, cerebellar, carotid, or the ACA, MCA, or PCA. Most commonly, the mechanism is atherosclerosis, but there are some other diseases that do this as well, such as arteritis or inflammation of the artery, fibromuscular dysplasia, or dissection, which can frequently occur in the carotid. Atherosclerosis commonly involves the ICA origin, the siphon, the MCA stem, and the distal vertebral artery. Large vessel ischemic stroke will frequently present with a preceding transient ischemic attack, which again is this kind of stuttering onset of stroke. Although many times patients will present with a sudden acute stroke that has maximal signs at onset. The reason why we want to recognize transient ischemic attacks is that if the patient is having a TIA, that will give you a warning that they are at risk to have a large vessel ischemic stroke later on. So you want to very quickly understand the distribution of where the TIAs are happening and try to do risk factor reduction immediately. In a carotid distribution of stroke, you're going to have cortical signs, and these will include, depending on which side of the brain you're on, aphasia, neglect, or visual field deficits, in addition to weakness or numbness. In the vertebrobasilar distribution, you will have other signs. You could have a midbrain syndrome, Pontine syndrome, or the medullary syndrome of Wallenberg. Now, we are going to teach you what these syndromes look like in some of our labs and smaller cases. But these strokes within the brainstem are going to be more readily identified because of the presence of cranial nerve abnormalities. So as you remember, in the midbrain, you have cranial nerves 3 and 4. So what you would expect to see if you have injury to the midbrain is a cranial nerve 3 or 4 lesion, in addition to other signs. Pontine strokes will be associated with bilateral weakness and sensory loss, but you will also see cranial nerve abnormalities of 5, 6, 7, and 8. For the medullary syndrome of Wallenberg, you will have cranial nerve abnormalities in 9, 10, 11, and 12, and that will help you localize to the brainstem. Those cranial nerve abnormalities, again, will be associated with other neurological signs, but when you see a cranial nerve abnormality, you're thinking problems in the brainstem. So this is an image of a middle cerebral artery occlusion. These strokes tend to be large in distribution and can have massive ramifications for the patients when you infarct this much tissue. So what you can see here is a right MCA stroke, and on the right side you can see that the vessels, this is an MRA, so it's looking at the arteries. You can see that the vessels on the right, especially the right MCA coming off over here, is not being perfused. So there's essentially a clot sitting at the beginning of the MCA causing the infarct. Carotid stenosis is a common mechanism for ischemic stroke, and stenosis occurs in approximately 5 to 10% of the population over the age of 65, with about a 50% stenosis. Now, stroke rate for previously asymptomatic patients with carotid stenosis is low. It's only about 1 to 2%. But if you have carotid stenosis that is symptomatic, meaning that the patient is having symptoms such as TIAs, up to 13% of those people are at risk for stroke per year or annually. Carotid disease is responsible for about 9% of all ischemic strokes, so it's an important mechanism to know about. So here are some pictures of carotid stenosis on angiogram. So an angiogram is when we go in and we squirt dye up the artery and take pictures radiographically. Usually this type of imaging is done in the interventional radiology suite, and you can get a really good idea of what's happening with the vessels. The other thing that you can do when you're in the interventional radiology suite and you have an acute event is you can actually provide therapy. Now in this case, this is a diagnostic test, and what we can see here is this narrowing of the artery on the left side of the picture. And this is a closer view of another stenosis in the carotid. So again, easily identified. Frequently, instead of doing direct angiograms, we will order these MRAs because it doesn't require the patient to be in the interventional suite or be given dye up through the groin. Small vessel disease can also occur, leading to ischemic stroke, and this is when you have stenosis or occlusion of the smaller penetrator arteries, which can supply the deep structures of the internal capsule, the basal ganglia, and the base of the pons. Lenticulostriates arise from the MCA, and this should be a review given what you know about the vascular anatomy, and thalamic penetrators from the basilar and stem of the PCAs are also frequently involved. Now, these vessels are prone to microatheroma, so smaller plaques, and they can also be hyalinized with lipid deposition. There can be fibrinoid degeneration as well. Chronic hypertension is a major cause of ischemia to the small vessels, and diabetes and older age also contribute. So the type of symptoms we're going to see in small vessel disease are frequently pure motor hemiparesis in about 80% of our patients. And the reason why is because you've had ischemia to the small vessels that are supplying the motor tracts as they come through the internal capsule. So they've come through the subcortical regions. You would typically not have small vessel disease causing a motor hemiparesis in the MCA distribution, again, because that's a large vessel. So pure motor hemiparesis, the most common cause, is going to be a small vessel ischemia, and it will not be associated with other signs such as aphasia. Now, you can get pure sensory strokes and ataxic hemiparesis because of the perforators going to other regions of the nervous system, and these will occur much less frequently. Typically, these will not involve the cortex, and you are not going to see language abnormalities, attentional abnormalities, behavioral abnormalities, or visual field cuts with small vessel disease. You're going to be thinking about large vessels when you see those signs on the exam. So here are some pictures of small vessel lacunar infarcts. So what you can see here, we're depicting, this is abnormalities within the basal ganglia regions. You can see that we have blocked arteries into these small vessels. And this is what it looks like when we look at the imaging. We can see this tiny black hole located in a similar region, and here's another one here. And you can see this is much smaller than the large vessel pictures we were looking at earlier. Cardioembolic disease can occur, and here we'll have occlusion of the arteries by embolic material arising from the heart. Cardiac emboli will most often go to the branches of the MCA and top of the basilar. The most common causes are cardiac thrombus, or of the cardiac thrombus formation, are atrial fibrillation, cardiomyopathy, and valvular disease. The deficit is typically sudden in onset, and occasionally patients will have a seizure at the start. So here's a picture reminding us of the connection between the heart and the brain. And this picture on the right gives you an example of what one of these lesions might look like. So what we can see is a myxoma in the left atrium. And you can easily imagine how part of this myxoma can break off and go up through the common carotid into those vessels up here to cause a stroke. So what are the risk factors for stroke? So there's several risk factors that we cannot modify. These include age, sex, race, and genetic factors. And we looked at some of these when we were looking at prevalence and incidence slides earlier. There are several modifiable risk factors for stroke, and these are important to know for step 1. These include things such as hypertension, diabetes, hypercholesterolemia, carotid disease, heart disease, cigarette smoking, alcohol abuse, homocysteine, coagulation disorders, and physical inactivity or obesity. We're going to go into a little bit more detail in some of these that are going to be very important for your exams in the future. Hypertension is quite common. You probably have seen these numbers before. Hypertension is a problem in about a quarter of the U.S. population, and the prevalence of hypertension goes up with age. So about 60% of individuals over the age of 60 will have hypertension. It is the major treatable stroke risk factor. And in controlling blood pressure, we know we can reduce the rate of strokes. Stroke incidence is actually reduced by 30 to 50% just by lowering blood pressure. The national guidelines suggest that systolic blood pressure should be under 150. It should be even lower in patients who are diabetic, again because of their risk for small vessel ischemic stroke. Antihypertensive medications, some research suggests that calcium channel blockers and angiotensin converting enzyme inhibitors may be the most effective in stroke prevention. Hyperlipidemia is another risk factor for stroke. Hypercholesterolemia has not clearly been demonstrated to be an independent risk factor for stroke as it has been for coronary artery disease. However, it is very clear that statin drugs appear to reduce stroke incidence. The mechanism may be by cholesterol reduction, or maybe there's an anti-inflammatory mechanism that's playing a role here. So the National Cholesterol Education Program Adult Treatment Panel suggests that we should maintain a serum cholesterol under 100 and under 70 if multiple risk factors for stroke are present. And again, what we can see by Sparkle, which was a famous study that was done looking at stroke prevention, we showed that, or the researchers showed that statins did result in fewer secondary strokes. We already talked a little bit about carotid stenosis. So if you have asymptomatic carotid stenosis where you have no symptoms at all, if you fix the carotid stenosis, meaning you go into that artery and clean out the plaque, there is an absolute risk reduction of 6% in favor of surgery in reducing the risk of future stroke. However, if your surgeon has a surgical complication rate above 3%, it may not make sense to actually go ahead and go in for surgery. Symptomatic stroke is a little bit different story. The absolute risk reduction of ipsilateral stroke is about 18% in those patients who have carotid stenosis and are having neurological symptoms. The surgical complication rate has to be a little bit higher, above 6%, to preclude benefit. There are other procedures you can do in order to help patients who have carotid stenosis in reducing the risk of stroke. And that's by doing carotid angioplasty or placing a stent in that area where you have carotid narrowing. So here's the estimated stroke risk over 10 years in older adults according to levels of various risk factors. So what you can see, especially as blood pressure goes up, is that many of these risk factors will be linked to higher rates of stroke. And here we have listed diabetes, cigarette smoking, atrial fibrillation, and prior cardiovascular disease. So let's talk a little bit about general management of stroke. So the first thing you're going to do when the stroke patient arrives is you're going to evaluate them, and typically neurology will go right to the emergency room. We have a stroke pager that goes off. And sometimes we'll actually be alerted from the paramedics in the field that there is a stroke coming in, so we can run down there and be ready. The first thing you're going to do is you're going to assess the patient and perform the NIH stroke scale. And here we're abbreviating it NIHSS, which is kind of an abbreviated neurological exam to focus on major neurological signs. And it's kind of a quick measure because you really want to take as little time as possible to make a plan, given that kind of time is brain. The longer you wait and evaluate the patient, the more likely it is you're going to lose that penumbra that we already talked about that's at risk tissue. Once you've evaluated the patient and determined indeed they likely are having an ischemic stroke, you're immediately going to send them to the CAT scanner to get an idea of what the brain looks like. And from that, you're going to determine, do we have an ischemic stroke or do we have a hemorrhagic stroke? If we have what appears to be an ischemic stroke and the brain scan looks pretty good, that patient may be more likely to be to recover well with some of our clot-busting medications. If we see great abnormalities on the CT scan, we may be less likely to give somebody IV TPA or one of these other therapies. It will also give you an idea of how much of the brain is involved and whether that patient is at risk for swelling, which can ultimately lead to herniation. So once we've evaluated and determined the type of stroke the patient has and evaluated kind of their risk level, we're then going to admit them to the hospital. And frequently these patients will be admitted to a stroke unit or a neuro ICU. We're going to address a number of things while the patient is in the hospital. So of course we want to make sure that they're adequately ventilated. If they're decompensating, we will intubate them. We will put them on a heart monitor because we're looking for arrhythmias or other abnormalities, atrial fibrillation that may have led to the stroke in the first place. We're going to perform neurological monitoring with the stroke scale on a regular basis. And then we're going to do a number of things to prevent other problems. We want to manage the blood pressure. If the blood pressure is high, we're going to want to lower that blood pressure. Frequently, that blood pressure is going to be high in the setting of acute stroke, so that's going to be one of the key factors, again, to save that penumbra. You're going to want to manage fluids and glucose. You want to make sure that glucose is in the normal range because elevated sugars are going to worsen the likelihood of injury to the penumbra. You want to monitor temperature and bring them into the normal range. Patients who are febrile will be more at risk to lose that brain tissue. You want to think about activity and diet while they are hospitalized, work on bowel and bladder management, and you want to make sure you're providing DVT prophylaxis, especially if your patient is not able to get up and ambulate. Finally, we very quickly will institute therapies while patients are in the hospital with acute stroke and consider discharge to a rehabilitation unit where they can do even more aggressive therapy once they have been stabilized and treated. So let's talk a little bit about acute ischemic stroke therapy. Some of these agents are going to be discussed in much greater detail in neuropharmacology, maybe even in the second year. So I will reserve some of my comments at this point. So antiplatelet drugs such as aspirin may have some efficacy in the initial hours, and I'll show you a slide next of what that looks like. Anticoagulants, especially heparin, can be useful in certain causes of stroke such as dissection, venous infarction, or prevention of recurrent cardiac embolism. It is also used in atrial fibrillation, but we do not use anticoagulants for routine use in ischemic stroke. IV systemic thrombolysis is commonly used if the patient arrives to the hospital in a timely manner. Endovascular therapy such as intra-arterial thrombolysis, if available for your patient, can be used especially if the patient has come in outside of the TPA window. Finally, we will go in and actually retrieve the clot that's blocking the vessel in some cases. So this slide addresses antiplatelets and vascular events, and what you can see in this slide is that with the red bars are those individuals on antiplatelet therapy. And what you can see is that they have a lower amount of vascular events compared to those patients who are controls and did not go on antiplatelet therapy. So these two sets of bars here address patients who previously had a stroke and in patients with acute stroke. And what you can see is that there is an advantage to these agents. In patients who have atrial fibrillation, they do have, of which there are many in the United States, there's 2 million people in the U.S. who have AFib. What we will find in patients with ischemic stroke is about 15% of them will have lone atrial fibrillation. And this type of stroke you will see more commonly in younger patients with stroke. So the attributable risk of stroke from atrial fibrillation is about 1.5% in these younger ages and 30% in ages 80 to 89. And it may be the most frequent cause of stroke in women over the age of 75. So this picture on the right shows anticoagulation for stroke prevention in atrial fibrillation. And what you can see is that when patients are placed on anticoagulants, the risk reduction is greater than in those patients with AFib who are not put on anticoagulation. So let's talk about TPA, tissue plasminogen activator. This will frequently show up on your board exams, including STEP, because it is such an incredible way to bring back neurological function in the setting of acute stroke. So TPA is used for ischemic stroke. And in the studies that were conducted through the NIH, TPA was compared to placebo in over 600 patients with acute ischemic stroke. They were randomized to receive TPA versus placebo. And what it was found with a global odds ratio is that 30% of patients who received TPA were more likely to have a minimal deficit at 90 days. Symptomatic hemorrhage from those treated with TPA was approximately 6% compared to less than 1% for placebo patients. Over here on the left, what we can see is that with several of the scales that we use to measure stroke and disability after stroke, we can see that the patients who received TPA in the bottom bars, a higher percent of them were in the lower range on these scales than those patients who received placebo. Here's a graph depicting that visually, and what you can see is that the majority of patients had an excellent outcome at 3 months on all scales. Those patients who had TPA versus placebo. The number needed to treat in patients who received TPA is quite high. It's actually quite low. It's 8. And it's only 3 to have an improvement from when they came into the hospital. So for about every 100 patients who are treated with TPA, 30 will benefit and only 3 will be harmed. And again, those that are harmed tend to have bleeding after receiving TPA. I will say with TPA, it used to be that there was a window of 3 hours after onset of the neurological symptoms that we could give the TPA. That window was then extended to 6 hours, but just within the last couple weeks, there's been another study released that suggests that it is safe out to 24 hours to provide TPA. So it is very likely by the time you guys get on the wards, third year, we will be providing TPA for all patients who have had stroke within 24 hours. Intra-arterial thrombolysis is when we deliver a thrombolytic agent directly through the blood vessel to the clot. So this patient would be taken to the interventional radiology suite. They will have a device that's moved up through the vessel, and then essentially that thrombolytic is squirted through the device to the location of the clot. So this patient came in with aphasia and right hemiplegia. All of you guys at this point will know that this means, hopefully, if you don't, I'll tell you, this means that this patient is having a left MCA event. And so what you can see here in this first picture is that 2 hours after the event started, we're essentially missing all of these vessels off of, including the MCA. But then they have delivered this thrombolytic agent to the location of that clot. And over here you can see restoration of that blood flow into all of those vessels. And this is at 4 hours. What does this mean? It means that it is very likely this patient's going to have a great recovery. We've probably saved the penumbra, and this patient may very likely walk out of the hospital or walk out of rehab. The last thing I want to tell you about is clot retrieval. There are several devices that will actually go in and extract the clot for you. And what will happen is in the interventional radiology suite, sometimes the angiogram will be performed and the interventional radiologist or other members of the team will make a decision right at the time whether they will use intra-arterial thrombolytic agents or whether they'll actually just pull the clot out. So this is something that happens in real time and is another way to help your patient. So in summary, stroke is common and serious. This is a neurologic emergency. And in order to treat patients with stroke, you really need to have a good understanding of brain anatomy and stroke pathophysiology. I will tell you that you will be learning the various stroke syndromes in the cases directly and in the short cases that we're going to have later in this block. As you learn the neuroanatomy and the vasculature, you're going to be able to put together when the patient presents with neurological signs and their history, you're going to be able to localize that lesion to various areas of the central nervous system and vasculature. And you're going to need to know those syndromes for the STEP exam. Some of them are more likely to be tested on than others. Prevention of stroke will require a knowledge of the risk factors for stroke and how to address them, remembering that some can be modified and some cannot. We want to remember endarterectomies and angioplasty or stenting are options for treatment of carotid stenosis in selected patients. and that we can use thrombolytics and endovascular clot retrieval in the treatment of acute ischemic stroke.